Hey guys, this is Miss Dennison. I am going to go over chapter 17, newborn transitioning. Literally like a bomb. So, the neonatal period is defined as the first 28 days of life. It is the period of the most dramatic and rapid physiologic changes in humans. So, this newborn is thrust out of their comfortable, lovely, warm spot into a cold, loud, bright environment. So these particular things that are on this slide, these are the most important areas of the changes. The transition usually completes within the first 6 to 10 hours of life. Mom stress is better. However, now the baby is working hard to try to survive. So I have a video on here for y'all to watch on your own. I'm not going to play it for now. I just want you to know that it's on there. Anyway, so basically the newborn's cardiovascular system adaptations, to have a successful transition, the pulmonary blood flow needs to be increased, the placenta has to be removed, and the shunts must close. So when they clamp that cord, that pressure, that negative pressure builds. So that equalizes the right ventricular output with that of the left, forcing the closure of the foramen ovale. And then the circulation begins to flow just as ours flows. The force of the contractions during labor and birth, mild asphyxia, increased intracranial pressure as a result of cord compression and uterine contractions, and the cold stress experienced immediately after birth lead to an increased release of catecholamines. These are critical. The increased levels of norepinephrine and epinephrine stimulate the increased cardiac output and contractility in the baby's heart, surfactant release, and the promotion of pulmonary fluid clearance. So again, when that cord is clamped, it increases the systemic vascular resistance, kind of like clamping a water hose, which decreases the blood return via the inferior vena cava. At the same time, the pulmonary vascular resistance decreases, resulting in an increase of pulmonary blood flow, dilating those vessels and assisting the fluid out of those lungs by squeezing. The heart rate, usually for the first few minutes after birth, is increased due to stress. It's usually 110 to 160. It then begins to decrease to around 120 to 130 during this transition period. You may hear a murmur, which is totally normal. If the heart rate is high, it may be due to volume depletion, cardiorespiratory disease, drug withdrawal, and hyperthyroidism. If the heart rate is low, it can be associated with apnea and hypoxia. The blood volume is estimated between 80 to 85 milliliters per kilogram of body weight in the term infant. Delayed cord clamping has been shown to improve the newborn's cardiopulmonary adaptation. This prevents iron deficiency anemia and increases blood pressure, improves oxygen transport, and increases the red blood cell flow. It also increases blood volume in term infants by 30 to 50%. By 30% and 50% increased blood volume in preterm infants. Blood components: the fetus has more red blood cells per cubic millimeter than an adult and has a greater affinity for oxygen at lower oxygen pressure than adult red blood cells. So fetal red blood cells are larger in size and can carry more oxygen. After birth, the red blood cell count gradually increases as the cell size decreases. The hemoglobin initially declines, and white blood cell count usually elevates due to birth trauma. Platelets are the same as those of adults, and you can see table 17.2 in your book. So I have another little video on respiratory system adaptations. The first breath of life is a gasp that causes an increase in transpulmonary pressure, and the diaphragm moves lower. What stimulates respirations are high levels of CO2, low levels of O2, and acidosis. Tidal volume also increases. This is the amount of air that's brought into the lungs. Initiation of respirations. So adjusting from a fluid-filled intrauterine environment to a gaseous extrauterine environment. During fetal life, the lungs are expanded with an ultrafiltrate of the amniotic fluid. During and after birth, this fluid has to be removed and replaced with air. Passage through the birth canal allows intermittent compression of the thorax, which helps to eliminate 2/3 of the fluid in the lungs. Pulmonary capillaries and the lymphatics remove the remaining fluid. Surfactant, the role, the surface tension reducing lipoprotein that prevents alveolar collapse. So it is surface tension, and it prevents the alveolar collapse at the end of expiration and loss of lung volume. It lines the alveoli to enhance aeration of gas-free lungs, reducing surface tension and lowering the pressure required to open the alveoli. Now, normal lung function will depend on that surfactant. It's very, very important that infant or newborn has surfactant. This is to prevent atelectasis and to facilitate elastic recoil on inspiration. Respirations are usually 30 to 60 breaths per minute, usually irregular, shallow, unlabored. They may have short periods of apnea, which is less than 15 seconds, but they should have symmetrical chest movements. If the fluid is removed too slowly or incompletely, transient tachypnea, which is a respiratory rate above 60 of the newborn, occurs. Examples of situations involving decreased thoracic compression and diminished respiratory effort include a C-section and sedation in the newborns. So because that baby is not moving through that canal, that uterus is not contracting and getting that 2/3 of the fluid out of his lungs, then it can always cause problems. It can cause that tachypnea. So research findings support the need for thoracic compression because the absence of the neonate's exposure to labor contractions in these situations is associated with an increased risk of transient tachypnea at term, with oxygen supplementation being needed for a longer duration. Initial breathing is probably the result of a reflex triggered by pressure changes, noise, light, temperature changes, touching, compression of the fetal chest during the birthing process, and high carbon dioxide levels and low oxygen concentrations in the newborn's blood. Central chemoreceptors stimulated by hypoxia and hypercapnia further increase the respiratory drive. And these are just theories. They do look very ugly. So, the characteristics predisposing the newborn to heat loss. Upon birth, the fetus moves from a warm, moist intrauterine environment to the colder, drier extrauterine environment. Newborns are dependent on their environment for the maintenance of body temperature, much more so immediately after birth than later in life. One of the most important elements in a newborn survival is obtaining a stable body temperature to promote an optimal transition to extrauterine life. Average, a newborn's temperature ranges from 97.9 degrees Fahrenheit to 99.7 degrees Fahrenheit. Newborns lose heat very easily after birth, so having skin-to-skin contact is recommended as the initial method for maintaining newborn body temperature. Also, drying the infant vigorously will also help with that as well. Thermoregulation is the process of maintaining the balance between heat loss and heat production in order to maintain the body's core body temperature. Compared with adults, newborns tolerate a narrower range of environmental temperatures and are extremely vulnerable to both underheating and overheating. And as the nurse, you're going to play a huge role in helping to maintain that newborn, maintain thermal stability. This is a great video, and it kind of explains how heat is lost, but if y'all want to watch it, it's on there. So basically, conduction involves the transfer of heat from one object to another when the two objects are in direct contact with each other. That's why skin to skin is so great. Conduction refers to heat fluctuation between the newborn's body surface when in contact with other solid surfaces, such as a cold mattress, a cold scale, or a cold circumcision restraining board. It can also occur when touching a newborn with cold hands, or when the newborn has direct contact with a colder object, such as a metal scale or a cool mattress, blanket, or clothing. Using a warmed cloth diaper or blanket to cover any cold surface touching a newborn directly helps prevent heat loss through conduction. Convection involves the flow of heat from the body surface to cooler surrounding air or to air circulating over a body surface. Examples would be a cool breeze that flows over the newborn, a cool room, cool corridors, or outside air currents. So you're going to keep the newborn out of direct cool drafts, such as open doors, windows, fans, air conditioners. You're going to work inside an isolette as much as possible and minimize opening portholes that allow cold air to flow inside, and warm any oxygen or humidified air that comes in contact with the newborn. Evaporation involves the loss of heat when a liquid is converted to vapor. Evaporative loss may be insensible, such as from skin and respiration, or sensible, such as from sweating. Sensible loss is objective and can be noticed. It depends on the airspeed and the absolute humidity of the air. For example, when the baby is born, the body is covered with that amniotic fluid. The fluid evaporates into the air, leading to heat loss. It also occurs when bathing a newborn. So drying newborns immediately after birth with warmed blankets and placing a cap on their heads will prevent heat loss through evaporation. Promptly changing wet linens, clothes, or diapers will also reduce heat loss and prevent chilling. Now, radiation. This involves the loss of body heat to cooler solid surfaces that are in proximity but not in direct contact with the newborn. The amount of heat lost depends on the size of the cold surface area, the surface temperature of the newborn's body, and the temperature of the receiving surface area. For example, when a newborn is placed in a single wall isolette next to a cold window, heat loss from radiation can occur. So you're going to keep the cribs and the isolettes away from the outside walls, cold windows, and air conditioners. So again, thermoregulation is the balance between heat loss and heat production. And the newborn tries to conserve the heat and increase heat production by increasing the metabolic rate, fat and protein metabolism, non-shivering thermogenesis of brown fat, muscular activity through movement, peripheral vasoconstriction, and assuming a fetal position to hold in heat and minimize exposed body surface area. Heat production is primarily through non-shivering thermogenesis. Infants do not have, or newborns do not have the ability to shiver, so they are more at risk for cold stress. This is excessive heat loss that requires a newborn to use compensatory mechanisms to maintain core body temperature. So as the body temperature decreases, the newborn will become less active, lethargic, hypotonic, and weaker. All newborns are at risk for cold stress, particularly within the first 12 hours of life. Preterm newborns are at the greatest risk for cold stress and experience more profound effects than full-term newborns because they have fewer fat stores, poorer vasomotor responses, and less insulation to cope with a hypothermic event. Cold stress in the newborn can lead to the following problems if not reversed. So depleted brown fat stores, increased oxygen and glucose consumption, which will lower their blood glucose, causing hypoglycemia, and that's never a good thing either. Respiratory distress, depletion of glycogen, leading to hypoglycemia, pulmonary vasoconstriction, metabolic acidosis, jaundice, hypoxia, and decreased surfactant production. So the need for a neutral thermal environment, because newborns have difficulty maintaining body heat through shivering or other mechanisms, they need a higher environmental temperature to maintain a neutral thermal environment. If the environmental temperature decreases, the newborn will respond by consuming more oxygen. Then the respirations increase and the metabolic rate increases. Now, on the other side, overheating. So the primary heat regulator is located in the hypothalamus and central nervous system in the brain, which is immature in the newborn. So you have to create that perfect balance for the baby. They have limited insulation, a large body surface area. The newborn's primary method of heat production is through non-shivering thermogenesis. This is a process in which brown fat or adipose tissue is oxidized in response to cold exposure. Brown fat is a special kind of highly vascular fat that scientists once thought disappeared by adulthood. But new research shows adults have brown fat as well. So brown adipose tissue is a unique tissue that is able to convert chemical energy directly into heat when it is activated by the sympathetic nervous system. It's produced during the third trimester. It is ordinarily reduced by 3 to 5 weeks after birth, and it is vital for thermogenesis. The brown coloring is derived from the fat's rich supply of blood vessels and nerve endings. These deposits, which are capable of intense metabolic activity and can generate a great deal of heat, are found between the scapula, axilla, at the nape of the neck, in the mediastinum, and in areas surrounding the kidneys and adrenal glands. So brown fat actually makes up about 6% of term body weight in the full-term newborn. When the newborn experiences a cold environment, norepinephrine is released. This in turn stimulates the brown fat metabolism by breaking down triglycerides. Cardiac output increases, increasing blood flow through the brown fat tissue, and this blood becomes warmed as a result of that increased metabolic activity of the brown fat. Also, infants have a limited sweating ability. So to minimize cold stress, you're going to pre-warm blankets and hats to reduce heat loss through conduction. You're going to keep the infant transporter or a warmed isolette fully charged and heated at all times. You're going to dry the newborn completely after birth to prevent heat loss from evaporation. You're going to immediately encourage skin-to-skin contact with the mother if the newborn is stable, promoting early breastfeeding to provide fuels for non-shivering thermogenesis, using heated and humidified oxygen, always using radiant warmers and double wall isolettes to prevent heat loss from radiation, deferring bathing until the newborn is medically stable, and using a radiant heat source while bathing. Avoid the placement of a skin temperature probe over a bony area or one with brown fat because it does not give an accurate assessment of the whole body temperature. So normally the probes are taped in the right upper quadrant of the belly. So sad. The liver metabolizes carbohydrates, proteins, lipids, vitamins, etc. Okay. At birth, the newborn's liver assumes the functions that the placenta handled while in the womb. By 3 months, the liver is fully active doing these things. Storing iron. So, red blood cells are destroying after birth, releasing their iron and stored by the liver until new red blood cells need to be produced. Carbohydrate metabolism. Newborns have to learn to regulate their blood glucose level after the placenta is cut. Glucose is the main source of energy for the first several hours after birth, and the liver releases glucose from glycogen stores for the first 24 hours. Breastfeeding and bottle feeding also stabilize the glucose levels. Bilirubin conjugation. So bilirubin is the orange bile pigment produced by the breakdown of the extra red blood cells. The liver changes that bilirubin to a water-soluble form called conjugation and is excreted in the bile and ultimately the feces. There are 3 groups of jaundice based on the mechanism of accumulation of the bilirubin. So there's overproduction. This could be from blood incompatibility, drugs, trauma at birth, polycythemia, delayed cord clamping, and breast milk jaundice. Also decreased conjugation. This is physiologic jaundice, hypothyroidism, and breastfeeding. And then impaired excretion. So there may be a biliary obstruction. The infant may be septic, may have hepatitis, any kind of chromosomal abnormalities, and drugs such as aspirin, sulfa, steroids, and etc. The full-term newborn has the capacity to swallow, digest, metabolize, and absorb food taken in soon after birth. At birth, the pH of the stomach contents is mildly acidic, reflecting the pH of the amniotic fluid. The once sterile gut changes rapidly, depending on what feeding is received. Bowel sounds are normally heard shortly after birth, but may be hypoactive on the first day. Development of a mucosal barrier to prevent the penetration of harmful substances. The belly is sterile until birth. Then all the environmental contact are swallowed and colonized, which is essential for the production of vitamin K. But the baby develops a mucosal barrier to prevent the penetration of bacteria and harmful toxins inside the intestinal lumen. The physiologic capacity of the newborn stomach is considerably less than anatomic capacity. There is a rapid gain in physiologic capacity during the first 4 days of life. After the first 4 days, the anatomic and physiologic capacities more closely approximate each other. For the first 24 hours after birth, the newborn's small stomach does not stretch to hold more, as it will within a day or 2 later. This explains the experience of countless hospital nurses who have learned the hard way that when newborns are fed an ounce or 2 by bottle during the first day of life, most of it tends to come right back up. So the walls of the newborn stomach stay firm, expelling extra milk rather than stretching to hold it. The cardiac sphincter and nervous control of the stomach are immature. leading to regurgitation and uncoordinated peristaltic activity. The cardiac sphincter and nervous control of the stomach is immature, which may lead to uncoordinated peristaltic activity and frequent regurgitation. Immaturity of the pharyngoesophageal sphincter and absence of lower esophageal peristaltic waves also contribute to reflux. Avoid overfeeding and stimulating frequent burping may minimize regurgitation. Most digestive enzymes are available at birth, allowing the newborn to digest simple carbohydrates and protein. However, they have limited ability to digest complex carbohydrates and fats because amylase and lipase levels are low at birth. As a result, newborns excrete a fair amount of lipids, resulting in fatty stools. So to gain weight, the newborn requires an intake of 108 kilocalories per kilogram per day from birth to 6 months of age. Adequate digestion and absorption are essential for newborn growth and development. Normally, term newborns lose 5 to 10% of their birth weight as a result of insufficient caloric intake within the first week after birth. This shifts intracellular water to extracellular space and insensible water loss. To gain weight, the term newborn requires, I done told you that. Understanding the role and importance of nutrition in early postnatal life on growth and development is vital. But how it links to later health has a potential of health benefits for all future generations. The frequency, consistency, color, and type of stool passed by newborns vary widely. The evolution of a stool pattern begins with a newborn's first stool, which is called meconium. Meconium is composed of amniotic fluid, shed mucosal cells, intestinal secretions, and blood. It is greenish black, has a tarry consistency, and is usually passed within 12 to 24 hours of birth. The first meconium stool passed is semi-sterile, but this changes rapidly with ingestion of bacteria through feedings. After feedings are initiated, a transitional stool develops, which is greenish brown to yellowish brown. It is thinner in consistency and seedy in appearance. If breastfed, the stools will resemble light mustard with seed-like particles. If formula fed, the stools will be tan or yellow in color and firmer. The frequency of bowel movements varies widely from one infant to another. The last development in the stool pattern is the milk stool. Its characteristics differ in breastfed and formula-fed newborns. The stools of the breastfed newborn are yellow gold, loose, stringy to pasty in consistency, and typically sour smelling. The stools of the formula-fed newborn vary depending on the type of formula ingested. They may be yellow, yellow-green, or greenish and loose, pasty or formed in consistency, and they have also an unpleasant odor. There you go. A full complement of 1 million nephrons is present by 34 weeks gestation. The glomeruli and nephrons are functionally immature at birth, of course, resulting in a reduced glomerular filtration rate and limiting the concentration ability of the urine. So this reduced GFR makes the newborn susceptible to both dehydration and fluid overload. So frequently the newborn's kidneys are described as immature, but they are able to carry out their usual responsibilities and can handle the challenge of excretion and maintaining acid-base balance. Only when the newborn is faced with unexpected imbalances of water, electrolytes, or a disruption of acid-base status secondary to a preterm birth or illness does it lack the ability to handle the body's fluid homeostasis. A newborn infant's body mass is 75% water. the highest proportion of body water at any stage of a person's life. The majority of term newborns void immediately after birth, indicating adequate renal function. Although the newborn's kidneys can produce urine, they are limited in their ability to concentrate it until about 3 months of age, when the kidneys mature more. Until that time, a newborn voids frequently and the urine has a low specific gravity. About 6 to 8 voidings daily is average for most newborns, and this will indicate an adequate fluid intake. The renal cortex is relatively underdeveloped at birth and does not reach maturity until 12 to 18 months of age. The GFR is the amount of fluid filtered each minute by all the glomeruli of both kidneys and is one index of kidney function. So at birth, the newborn's GFR is approximately 30% of normal adult values, reaching approximately 50% of normal adult values by the 10th day of life and full adult values by the first year of life. The low GFR and the limited excretion and conservation capability of the kidney affects the newborn's ability to excrete salt, water loads, and drugs. So the immune system. Maternal antibodies are circulating in the newborn system until 6 months of age. Remember, there are different types of immunity. Natural immunity does not require previous exposure to the microorganism or antigen to operate efficiently. Physical barriers such as intact skin and mucous membranes, chemical barriers such as gastric acids and digestive enzymes, and resident non-pathological organisms. Natural immunity involves the most basic host defense responses, ingestion and killing of microorganisms by phagocytic cells. Acquired immunity is absent until after the first invasion by a foreign organism or toxin. Active acquired is the body developing antibodies. The neonate begins to form antibodies at 1 to 2 months. There are 2 primary processes. Number 1, the development of circulating antibodies or immunoglobulins, which are specifically targeted toward invading agents or antigens for destruction. And number 2, formation of activated lymphocytes designed to destroy foreign invaders. Now, passive acquired, this is from the mother to the fetus via placenta or to the infant via breast milk. Breast milk includes IgE, IgA, IgM, and IgG antibodies. And the newborn is primarily dependent on the IgG, IgA, and IgM. IgG crosses the placenta to the fetus in utero and provides baby with passive immunity for 3 months. IgM is produced by the newborn and it is elevated in infection. And IgA is produced by the newborn at 1 month. It is present in breast milk and provides resistance to respiratory and GI infections. The neonate is at increased risk for infection. There's increased morbidity, mortality related to infection in neonates. Signs and symptoms that you need to recognize include hypothermia, rarely hyperthermia, lethargy, irritability, feeding problems, decreased reflexes, pale or mottled skin, apnea, tachypnea, grunting, retractions, discharge from orifices. So infection risk also is increased in prematurity. One of the worst agents is group beta strep. After 35 weeks, the vernix, which is the protective covering, acrocyanosis versus central cyanosis, lanugo, creases, palms, and soles, simian line and downs, and increased weight during the last few weeks of pregnancy. In the caput can be edematous, commonly on the occiput or the back of the head. It can cross suture lines. and it can be due to vacuum. You would note increase in head circumference, edema at the back of the neck, boggy scalp, pallor, tachycardic, may need CT or MRI. And let's see. So you're going to monitor vital signs, H&H, bilirubin levels, change in location, and for decrease in hematocrit, as there may be a hemorrhage. Mongolian spots, bluish black, common on the back and the buttocks. Nevi stork bites, these are common over facial areas, necks, and they fade in a couple of years. Strawberry marks or nevi vasculosis, hemangioma. This is raised with sharp edges, red, rough, and most will, these will usually go away around school age. Port wine stain, they're various sizes, common on the face, and they do not go away. Erythema toxicum or newborn rash. This has macules, papules, vesicles, and usually occurs within 3 weeks after birth, and there is no treatment needed. It will go away. So neuromuscular system should be pretty well developed at term. Rapid brain growth in infancy. The reason for suture lines and fontanelles not closed yet. Glucose is important to the function of the system in neonates too. Transient tremors are normal. If they are persistent, this could be related to hypoglycemia or other problems, including drug addiction. Normal muscle tone should resist when you attempt to pull to sitting position. Absent reflexes are important signs of neurological problems. The following reflexes should be present in the term newborn. The suck, the root, you put pressure under their chin. With the rooting reflex, you stroke the side of their cheek and they'll root towards you. Extrusion, the tongue should stick out. Tonic neck or fencing, so the sleeping infant turns head quickly to the side, arm and leg on that side extended, and opposite flexes. And you can read about the rest of those, and we'll discuss them further in later chapters. So the neonate's behaviors should be closely assessed during the transition period. The most common assessment performed is the Brazelton Neonatal Behavioral Assessment Scale, assessing 6 factors. So habituation is the ability to inhibit responding to minor stimuli while sleeping. Orientation is assessed in terms of alertness and attention to visual or auditory stimuli. Motor performance assesses the movement and the tone. Range of state measures the arousability. Regulation of state assesses how the infant responds when aroused. Autonomic stability. You would assess for signs and symptoms of stress, such as tremors. Reflexes, several of the reflexes. Sleep and wake cycles. Those of you who have had children know that infant sleep and wake cycles are not anything close to the parent cycles. In the beginning, the infant sleeps up to 17 hours a day, only waking up when hungry, and with aging, the sleep cycles decrease. By 4 weeks, an infant can stay awake between feedings. So the factors that influence the sleep-wake cycles include gestational age, preemies will sleep more, time, so the age of the infant and the time of feeding. Stimuli may respond to different stimuli. So if they're used to a quiet environment during sleep cycles, they may wake up and startle to a noise. They may also sleep only if certain stimuli is present, such as music. Anxiety is passed on to the infant by the mother and affects sleep. Medications such as analgesics, anesthetics, and labor can lead to a more sleepy infant. Okay, is the following statement true or false? A respiratory rate of 44 breaths per minute would be considered a normal finding in a newborn. The answer is true. The normal newborn respiratory rate ranges from 30 to 60 breaths per minute. When assessing the stools of a 1-week-old newborn who is being breastfed, which would the nurse expect to find? The answer is C, yellow gold, loose stool. They would be passing milk stool, which in a breastfed newborn appears as yellow gold, loose, stringy to pasty, and sour smelling. Greenish tarry black would suggest meconium. Seedy greenish brown would suggest transitional stool. Yellow green, soft form stool would be more likely with a newborn who is receiving formula. A nurse is assessing the sensory capabilities of a newborn, which is the least mature sense at birth. The answer is B. Vision is incomplete at birth with the ability to focus on objects only in close proximity. The newborn has an acute sense of hearing, smell, and taste. Is the following statement true or false? During the first period of reactivity, a newborn is quite sleepy. The answer is B, false. During the first period of reactivity, the newborn is alert and moving and may appear hungry. And that is all that I have for you for Chapter 17. If you have any questions, feel free to let me know.